We're getting ready to start spine surgery and a live broadcast so that you, the viewers, could watch and learn. This patient has 3 cervical disc herniations in her neck, C3-4, 4-5, 5-6. Some of them are so big, they're pushing on the spinal cord, causing her to go paralyzed. As a matter of fact, all 3 are pushing on the spinal cord and the nerves coming off the spinal cord going down the arms. She has symptoms of cervical myelopathy. She also has neck pain, headaches, all from these 3 herniated discs. Now, she didn't want fusion. She wanted endoscopic Deuk laser disc repair. So I'm palpating with my fingers. I'm moving her trachea and esophagus over, and I'm feeling the spine. I'm going to go in. We're going to fix C3-4 shot, 4-5, and 5-6. Right now I'm at 2, 3, 4, 5, just a little low. I want to go a little bit higher. Shot. Shot. That looks pretty good. Let's get an AP. So I'm right over the 4-5 disc, which is where I'll start, and then I'll go up a disc to 3-4, down a disc to 5-6. That looks good. Let's go back to a lateral. So I want to check my AP, which is a front-back view, to make sure I'm in the middle on the front-back. And I want to check my lateral view to make sure that I'm localized to the proper disc. Shot. Good. 2, 3, 4, 5. 4, 5, you agree, Luis? Middle. Shot. Let's get a AP again. You want to check lateral and AP views frequently to make sure you're in the right place. That's a little bit to the right side, so I'm going to come back a little bit towards the middle. Shot. Perfect. We're going to go into this disc. Shot. Now we are in the shot. So if you count from the top, the tall bone at the top is number 2. The next bone is 3. The next bone, yeah, thank you, is 4, 5, 6. So which discs are we fixing? 3, 4, 4, 5, 5, 6. And show us where the herniations are. They're in the back of these discs, and they're pushing on the spinal cord, which runs in the spinal canal from the brain down to your tail, to your back. All right, we're going to start by doing a discogram. The discogram is where I will inject some dye into the disc so that I can visualize the herniation we're after, as well as the tear. Shot. There we go. Look at the herniation there. It's huge. The arrow is outlining the herniation. Yep. It actually goes all the way down. So, yep, that's it. All that. We're going to try to remove as much of this as we can endoscopically. I think we're going to probably get about 80% of it. There's no way to get 100% of every herniation. And I think 80% will be good. We've already discussed that ahead of time. She understands that some of the herniation goes down behind her bone. All right, shot. A little bit overexposed. Shot. 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 At this point, I'm placing the guide wire into the disc. Shot. There it is. Shot. You're pulsing, right?
Yes, sir.
All right. So I've got my guide wire in the needle. The needle is in the proper disc and through the proper trajectory. I verified that with the x-rays. We use the x-rays not just for localization, but for navigation. I've done some local injection with epinephrine. I'll just give that a minute to work. This should numb the skin and reduce any pain response that she would have. She is asleep. This is under general endotracheal anesthesia. The face is here, the chin is here, the chest is here. This is the right side of her neck. The middle of her neck is literally right here. So we're off to the right side. All right. I'm going to go ahead and make my incision. I'm using a number 11 blade. It's essentially a just small stab incision. It is 4 millimeters. That's all we need is 4 millimeters. All right. Let's see what we have on the lateral view. I want to check the position of the guide wire and needle. Coming out with the needle, leaving the guide wire. Shot. 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 So needle is out. Guide wire is still there. You want to be careful taking the needle off because sometimes it'll grab the guide wire and pull the guide wire or push it. So you want to make sure you stabilize the guide wire. You can see how small the incision is. It's quite literally 4 millimeters. Dilator's coming down. We're using the X-ray to assess. Shot. Want to make sure the tip of the guide wire doesn't advance. You want to keep it at the back of the disc. Now we're at the front of the spine. You could see the AP. You can see the dilator is right there at the anterior longitudinal ligament. So we'll get another X-ray from the AP view. Make sure we're in good position. We are. Perfect. You can see there's some rotation of the spine at C3, C4, and C5. Let's show them the spinous process there. Go ahead and stay on the X-ray. Show the spinous process of C4. The one above. No, down a little bit. Yeah, that triangle right there. There you go. That's 4, and then show them 5. And you see how they're offset. That means it's rotated there. There's some scoliosis. Now, we found that with the Deuk laser disc repair procedure, we're able to correct many times scoliosis, kyphosis, and even listhesis by getting rid of the herniation and repairing the disc. Okay, we're going back to a lateral view. I'm going to advance the dilator through the ALL. We're keeping her blood pressure good?
Yeah.
Keeping it? Yeah. Making sure her mean arterial pressure stays above 60. Preferably around 70, I think would be good, if you can keep it around there. Shot. Shot. So we're advancing the dilator to the back of the disc where the herniation is. Shot. Can you take one more? That's it right there? Yeah. This is a huge herniation here. Shot. Shot. All right, we are in the herniation at this point. That's where we want to be. This is a really, really big herniation, by the way. If you look at the MRI, you can see that. Shot. And the tip of the dilator is right at the back of the disc, right where the herniation is. So we're kind of inside the herniation, and I'm going to remove the herniation using the laser and grabbers, metal grabbers. They're a surgical tool called pituitary rongeur. Shot. I want to keep a close eye on my dilator, make sure it doesn't go in any further. Shot. 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 And you can see the tube is advancing through the disc to the back of the disc. And once I get back there, we'll see where the tear is, where the herniation came out of. All herniated discs happen because there's a tear in the back of the disc. And that tear allows the jelly from the center, it's like opening a tube of toothpaste. It allows the jelly from the center of the disc to move out through the tear beyond the disc and into the area behind the disc, which is bad. Can you give me a little inline traction, please? Give me a fair amount. Slight extension and pull. Shot. I'm having my anesthesiologist help me now to distract the spine. That's good. One more second. We should be good. There we go. That's about as good as I can get it. It's really quite perfect. Very happy with that. So for those of you watching at this point, this patient has 3 herniated discs. If she had gone to pretty much any other surgeon, she would have had a fusion done or an artificial disc, most likely a fusion. To do the fusion, there would be a big incision like that, or another one going this way, but we typically would do an oblique incision for a fusion with 3 levels, just so there's less traction on the esophagus. And she would have to have a metal plate and cages put in. But we're going to repair these discs without fusing, without putting in metal. The other thing we're doing that's special is called an annular debridement. Grab her. And what happens with the annular debridement is I'm cleaning the tear up where the herniation came out of because it hasn't healed. And her body wants to heal it, but it can't heal it. There's a little piece of herniation right there. We're going to need to get out a lot more than that. So by debriding the annular tear, it's going to allow the disc to heal itself so that more herniations don't happen in the future. It takes about a year for the tear to fully heal. So people have to be careful for the first year. Who set the scope up?
We did.
Who's we?
I did.
Yeah.
What's wrong?
You left that open, but that's fine.
Oh, I'm sorry.
All right, we're going to go down this tube with the endoscope. We're starting at the worst disc, by the way.
Hello, is there? Yes. All right, lights off, please. Thank
It's overexposed. I need a little less light on the scope.
you. Thank you.
Last. There we go. Should be good. So this is a really big herniation. We're going to start to see pieces of herniation coming back towards us, like that right there. We call that a reverse herniation. Guys, let's keep an eye on the irrigation. I want to make sure we have plenty of it. There's a tear right there, by the way. You see that?
We see it, yes.
Look at that. There's a herniation right there. See that? That's called a reverse herniation. That was pushing against the spinal cord just a few seconds ago. And now we have used this laser, by the way, which I've talked about. There's another piece of herniation trying to work its way out. So everyone says, oh, you don't need lasers in spine surgery, but you do, because the laser does 2 things. It vaporizes tissue very safely, endoscopically, but it also, using that pulse wave in a confined space, it allows me, we need a different scope. Get a new scope. Luis,
Yes, sir.
get another scope, please.
Another scope?
Yeah, this one, when I flex it, it's blurring.
Number 2 from there, yeah. Yep.
We need to have this one sent in. Oh, there it is. You see that herniation just came out? So this would be good for your testimonial. I would mark your time points, you know,
Copy that.
because it's kind of cool to see the herniations coming out. Just so you understand what's happening, we're sitting in the back of the disc looking through the tear where the herniations came out of. And there's more right there. They just keep, see how smooth they are? That's from inflammation. Those are sitting on her dura, the covering around her spinal cord, creating pain and inflammation. And now we're getting them out of there, getting rid of them, removing them. They're floating out of the tube. You see, there's another one. So you could see herniations are actually many pieces. They're not one piece, okay? Let me just stay with it for a minute.
No problem.
But what I'm going to do is I just want that one ready to go. So the key here, folks, herniations are many pieces, not one piece, okay? And you can see all these pieces. Stand by. Let me grab that. How is she doing?
Can I switch right now? Or no?
Yeah, it's fine.
Can I have the lights on, please?
No, let's just use it for a minute.
Okay, no problem.
I want to see how it does. It's still performing okay.
Okay, no problem.
What we're talking about is gosh, there's so many herniations here. We're talking about the scope itself. Sometimes the fibers in the fiber optic part of the scope will shift. I need the laser on, please. Come on, Oscar, you got to stay with me, man. So, I'll be honest, it's going to be really hard to get all the herniations out, and sometimes we have to break them up into little pieces. They don't want to come out as one big piece. So we're looking literally, there's a big piece right there. It's shaking and jiggling, okay? This is a little calcified and scarred up. There's a piece of herniation right there. Now, you have to sometimes use the laser to, oh, look at that. It's moving around. You see that? We're going to get it. It has only one way to go. It can only come up and out. It's the path of least resistance. That's the beauty of the scope and the tube. We create a path of least resistance for these fragments. So they're forced to come up and out. They can't go further in because there's more resistance. There's more pressure by going in further. So they have only one way to go, and the escape route for them is up this tube. The system just works. It's an incredible system. And the sad thing is that most spine surgeons have no clue it even exists. They were never trained because this is a very advanced technology. It's not an old technology, it's a new technology. And the problem is, let's just see this herniation.
Lights on, please.
Light on.
Thank you.
I'm going to show you the herniation here, okay? This is just one piece. I need a good background. Can you see this okay?
Yeah.
How well do you see it?
Pretty well.
All right, so there you go. It's stained blue. That's why we put the blue stain in with the discogram. So it binds to nucleus pulposus, the jelly that's been herniated. And you can see it's stained blue because it's degenerated nucleus pulposus, degenerative disc disease. So this surgery fixes degenerative disc disease by removing pieces of herniated disc. That's a good time marker for your testimonial.
Copy that.
Thank you.
So far, it's going well for this young lady. She was on the verge of being paralyzed. She was actually going paralyzed from this herniation. From these herniations, more than one actually. So it's a good thing we got to her. Most of our patients are not going paralyzed from their herniations. Most of our patients just have a pinched nerve or a neck pain. They don't have the spinal cord being crushed by their herniation, but some do. And the surgery works for that as well. You can see how nice the view is back here. It's really a nice view. There's another piece of herniation. Literally, we've counted how many herniations at just C4-5. At least 10? Huh? At least 10. And there's more. A lot more. Unfortunately.
We have a question.
Sure, we take questions during the broadcast, so if you want to ask a question, feel free to.
And this comes from Randy Sizemore on YouTube.
Hi, Randy.
And he said, I work as an EMT. This usually equals being required to wait longer to return to work post-surgically. Is the same true with this procedure?
So I'm trying to understand the question, Randy. He said, what was the first part? Discs?
Yeah, I work as an EMT. This
Yeah.
usually equals being required to wait longer to return to work post-surgically.
Oh, I see.
Is the same true with this procedure?
Yeah, Randy, great question. So with this surgery, we need restrictions after you get it done. The restrictions are lifting, no lifting more than 25 pounds for 6 weeks, and then it goes to 40 pounds after that, okay? So 25, then 40. And the 40-pound lifting restriction is for 1 year. The other restriction is no contact sports for 1 year. Yeah, there's another herniation right there. I'm going to try to grab that out. No contact sports for 1 year. So, I didn't get it. No lifting more than 40 pounds really for the first year, and no contact sports for 1 year. But otherwise, you can go back to work the next day.
Thank you.
We have people who go back to work the next day, many of them. Typically, it's a light duty job, not, construction work. Another piece of herniation. But Randy, think about it. Would you rather have a metal plate in your neck? And even if you do the metal plate with the fusion or an artificial disc, you still have restrictions. So no matter what surgery you get done, you're going to have restrictions for recovery, while your body heals. But this surgery does not have shorter lifting restrictions than, say, a fusion. Its restriction period is about the same. When I do fusions, actually, I could send my patients back to work sooner. Not work, but lifting heavy things sooner. So with this surgery, you'd have a 40-pound lifting restriction for a year. But with a fusion, my fusion, you could have a 40-pound lifting restriction for 3 months and then go back to normal lifting. So let's say if you had a fusion with me, I would let you go back to normal duty in 3 months. But with this, no lifting restrictions. But with this surgery, I'd keep you at a lifting restriction for a year. So as long as you can work with a 40-pound lifting restriction, then you can go back to work right away, usually within a few days. All right, trying to get that piece out, it's not coming out. So I'm going to have to keep working on it. Great question. By the way, we enjoy your questions. That's what we're here for. We want to answer questions for you. That's a piece of herniation. Now you saw I had to cut it in half to get it out. I used the laser to cut it. There is no scalpel that works down this hole, by the way. I know there's a lot of surgeons out there that tell people that you don't need a laser in spine surgery, you just need a scalpel. But it's not true. They don't know what they're talking about. Luis, can we fit a scalpel down this tube?
Definitely not.
Right? I'll show you in a minute, guys. I'm going to show you the skinniest scalpel there is. There is ophthalmology scalpels that are a little thinner, but I'm just going to give you an idea of how impossible it would be even just to get the scalpel down the tube. There we go. See what I mean by the pulse wave? Even from here, it jiggled it right out. You see that? That's why the laser is so powerful. A scalpel can't do that. Only the laser can create a pulse wave that helps remove herniations. It's an integral part of the surgery. So when people say, oh, you don't need a laser, they don't know what they're talking about. That's like saying you don't need an engine for your car. You just need to sit in there and do the Fred Flintstone with your feet. You don't need an engine for your car. It's the stupidest stuff I've ever heard. And I'm sorry, but I have to be critical of these people. They're lying. But what it is there's a lot of surgeons who don't know how to do endoscopic surgery. And they tell patients, oh yeah, it doesn't work. Of course it doesn't work for them because they don't know how to do it. They've never done it before. But the reality is it does work. And we've published the results. It works quite well. All right. Great question so far.
We have another question.
I'll be happy to take the question.
This comes from Amit Singh on YouTube.
Uh-huh.
And they asked, When this method is harmless, then why do doctors suggest an ACDF or a laminectomy?
Great question, Amit. The reason is, number one, the doctors who suggest ACDF or laminectomy, they don't know how to do this procedure. They've never seen it, and they've never been trained on it. So they can't recommend this procedure to a patient when they don't know how to do it. Doctors are going to recommend, mostly they're going to recommend what they do. You know, what procedures they do, which I think is wrong. Because when I see a patient that needs some procedure done that I don't do, I send them to the doctor who does it. I always do what's best for my patient. I don't try to do it myself. Or I don't try to tell the patient, oh, you know what, I do a different procedure that's worse, but let's do my procedure. I don't say that to people. I tell them, look, for example, let's say you had an aneurysm in your brain. I don't do coiling, endovascular coiling, which is a new technology that's very good for certain aneurysms. I just do surgery, open surgery, which is very dangerous and risky. So when I see a patient with an aneurysm, I will tell them, listen, you know, I know how to do surgery, but surgery may not be your best choice. You want to do what's best for you. So I want you to go see a doctor who does coiling and see if this is a good aneurysm to coil, because that's safer and it could save you from having major complications and have better results. So it's all about the doctors should be doing what they went into medicine to do, which is to do what's best for the patient. But unfortunately, many doctors don't. They just do what they know how to do, and they tell the patient that's what's best for them because they don't want to lose the business. Why don't more doctors do this? Because there's nobody teaching it. So how are they going to learn? And the equipment that you have to buy to do the surgery is very expensive. Millions and millions of US dollars. And most people don't have access to that kind of capital. I invested my own money and built the center and bought all the equipment. So it's a lack of knowledge about the procedure, a lack of training, and it's a lack of equipment and having the ability to do the surgery because they don't have the equipment available to them. And to be honest with you, there's a lot of pushing by the companies that sell screws and rods to do fusions. They are infiltrating our educational system in the United States to where they have representatives and they do funding and they hire surgeons and pay spine surgeons to basically teach the new generation of spine surgeons to do fusions and artificial discs. So when the surgeons are trained in the university level, they're only trained on fusions and artificial discs. They're not trained on endoscopic surgery. So of course they're going to come out of their training and they're going to recommend to their patients metal procedures, fusions. They're not going to recommend endoscopic surgery because they don't know how to do it. They don't even know it exists because their professors never showed it to them. So basically what I'm saying is the professors at the universities for spine surgery, neurosurgery, orthopedic surgery, they've been bought off, paid off, corrupted, unfortunately. Well, this is a very long disc to fix, but there was a lot of herniation here. We want to try to get as much out as we can safely. I'm now in the right foramen at C4-5. You can see how the laser does its job. It literally takes that herniation and breaks it up into lots of little pieces. And that's part of the reason why it's so safe. Rather than trying to take a big piece out, you're taking many little pieces out. It's a principle we use in neurosurgery and other types of surgery called debulking. Thanks. Debulking is when a surgeon breaks up the tumor or mass, which the herniation is a tumor, by the way. It's not a cancerous tumor. It's just a tumor. Tumor in Latin means mass. It's a medical term. It's not the kind of tumor you're all thinking like cancer, but it is still a mass that presses on things and causes a biological reaction, which is inflammation. And that inflammatory reaction is what's responsible for neck pain, headaches, arm pain. Now, when you have a mass pressing on a nerve, you don't get pain. You get tingling, numbness, and weakness. Tingling, numbness, and weakness. 3 things. Okay? When you have a herniated disc that's causing pressure on a nerve root, you're going to get tingling, which we call paresthesias, numbness, and weakness of the muscles down the arm. The pain comes from inflammation. Most doctors don't know this. They have no clue. Most surgeons don't know it because they don't treat inflammatory diseases. Surgeons treat structural diseases usually. Now, this is a structural disease as well, but they don't treat the inflammatory part of it, which is really, in my opinion, the most important part of it for patient symptoms. Great questions. All right, why don't we run our video, show our audience how do herniated discs cause pain. This is actually really cool. This is a massive herniation that's through the posterior ligament. You see these fibers I'm zapping right now? That's PLL, posterior longitudinal ligament. And behind it is a massive, massive, massive herniation. And that's what I'm working on. Now I want you to know something. Surgeons that don't do endoscopic surgery, they can't do this. They cannot see this that well. This is best seen by a microscope or an endoscope. We have both here at Deuk Spine. We're capable of doing both. This is really interesting here. I've honestly not had a herniation this big before. This is a monster. This is Godzilla, the Godzilla of herniations. Look at it, it's humongous. There we go, a piece came off. And look at all the scar tissue coming about. There it is, it's starting to move. It's like, why are you waking me up? I was sleeping here just fine. Leave me alone, go away. Let me continue to harm this patient. And I'm saying, no, this is your eviction notice. You are not wanted here. Starting to move a little bit. You guys see the edges creeping, like pulling away from the spinal cord? Look at all the yellow color. That's all scar tissue. Sorry, it's it's calcification of the scar tissue. That means it's been here for many years. Many years. This is not something that just happened in the last couple of months. This has been here many years. And again, that's what we talk about all the time. How herniations actually, they form over time with multiple events. This is probably the first you'll ever see this. We do not normally get herniations this big. This is a beast. I mean, honestly, this is so much bigger than normal. And we've already removed a lot. This is what's deepest. And I want to get as much as I can. You can see it right there, right? You can kind of see a plane there. And you can see the dura over there, the spinal cord, to the 12 o'clock position. So you see how precise the laser is. It's precise up to 0.5 millimeter, and that's, oh, there there it started to move. You see that one piece of it? It's jiggling around. It's saying, okay, okay, we're leaving. We're ready to leave. Please stop. Don't bother us anymore. There it is. It's about to come out. It's like popping a zit. This is better than the pimple popper. If you understand what I'm doing right now, oh, there's a piece of it. All right, will you take me and leave the rest of us alone, please? No, I won't. I'm taking all of you. Pretty cool, huh, Luis? Oh, look at that. Get out of there. It's so heavy and dense, it won't float out with the irrigation. So I have to go grab it. Look how smooth the surface is. That smoothness is not normal. When the herniation first happened, it was not smooth like that. There it is. It was actually ragged. Oh, you dropped it. Very ragged. Was I this way?
Yeah, you were there.
So the edges are ragged. The reason they smooth out over time is the chemical effects of inflammation. It's your inflammatory system. Oh, it's so badass. I love it. Any questions from our audience?
No current questions.
For the spine surgeons out there that do cervical disc surgery, check this out. How cool is that? It's just a mass of herniation, and I'm just removing it basically 0.5 millimeter at a time. Oh, here it comes. Oh yeah, come on now. Get out of there. You don't belong there. This is beauty. This is a very special surgery, Henry. Put a box maybe of special surgery and copy it and put it, you know, oh, look at that. Light on? Yeah. We need to keep it where we normally file them, but also have it, look at the size of that. Can you see that?
Yep.
That is probably, my glove is obscuring it, probably a good, I don't know, 3 millimeters. We have a ruler?
Yeah, next to the...
Why not? No? Which one? I see. All right. Why not? We're having fun here. Can you see this?
Yes.
All right, you can see the millimeters. So this thing is long-wise. It's about, well, it's about a centimeter. So 10 millimeters, you know, almost, probably about 8 millimeters long. And that's one herniation, by the way. So this happened at one moment in her life. She shot that thing out. And you've seen now, what, 20 at this disc? And we're not done. Crazy, huh? So you can see some patients, surgeries take longer than others because there's more complicated, more herniation. Oh my gosh, look at that. That's the spinal cord right there. So we got it. I'm going to clean up the top edge here. There's still some more up here. But that is the spinal cord, my friends. That's what we want to see. We want to see the spinal cord. That means we've removed the herniation sitting on top of it. Okay? Dude, look at the spinal cord right there. You see the dura? That's dura. That is the cervical spinal cord. Now, there's still some herniation north of it. I've got to try to get that out safely, of course. But this is why we're neurosurgeons, folks. You want to know what neurosurgeons do? We operate on the spinal cord and brain. You know? That's all herniation right there, too, and thickened ligament. I'm trying to get it out. But you can see the blush, the pink blush on the spinal cord from the inflammation that was going on there. Look how much mobility there is at this disc. You see the movement of the bone above and below? Nice preservation of movement. The Deuk laser disc repair surgery you're watching does not fuse. We don't lose movement at all with the surgery. More of this herniation here. See how the laser just nicely vaporizes all of it? Look at that thick herniation down there. And the clarity is amazing. You know, just being able to have the endoscope right now and do this, you can see everything so clearly. So I'll explain what we're looking at in just a second. I just want to focus for a second here. Any questions?
Yes.
All right, just give me a second, all right? That was a bone spur right there, by the way, that I just took with the laser. People wonder, oh, what about bone spurs? Well, go watch my surgeries. You can answer your question yourself. I want to show you, this is really special right here, really special. All right, so this is herniation, but right there is the lateral edge of the spinal cord, right there. And then there's the sulcus, the anterior sulcus, and there's a vein there, and then the nerve root runs out here in the foramen. You can see the foramen doesn't have any more herniation, just some fibers of the ligament, which I'll you know, I want to make sure we get as much as we can. But that is the sulcus right there between the spinal cord and the nerve root. And that nerve root, since this is C4-5, would be the C5 nerve root on the left. So that is the left C5 nerve root. And that's the foramen right there, okay? We're literally lasering right in the foramen. Again, you're watching the Deuk laser disc repair. Now at Deuk Spine, I've done 1,500 of these surgeries in 16 years that I've been doing this. We've never had a surgical complication. No nerve damage, no spinal fluid leak, no infection. It's just an amazing procedure, and there's no metal. So you get to get your neck fixed naturally without putting any metal in. All right, so we've got a long way to go still, unfortunately, but we're making really good progress. How's our patient? I'm sorry? This is the biggest one, yeah. This is the biggest of the 3 herniations, but the other ones are pretty sizable too. I've got to look right here at what's going on there. All right, I will take that question now.
All right. This question comes from Amit on YouTube once more.
I'm going to turn the scope. Go ahead, I'll take the question.
And Amit asked, how much does it cost there for a 3-level surgery?
Oh, Amit, it depends on which discs we're fixing and how complicated it is. But yeah, and we, you know, it's not cheap, let's put it that way. Are you asking for yourself or someone else?
No response yet.
All right, that's fine. He doesn't have to answer if he's not comfortable answering. Again, there's some more herniation here. You see the scar tissue. You see the ligament. And I want to make sure we're getting all the herniation we need to. I have to convince myself we've done everything we can do. So generally, you have to ask the business office, Amit, if you're still wondering. I don't have the exact pricing, but the business office would do, and they would want to see your imaging you have available to know exactly what needs to be done.
He responded back. He said, for myself, just wanted to know the range of cost.
Yeah, that would be the business office. You would need to get a number from them. All right, let's see here. Gonna have to look through this. I think that's fibers of the posterior ligament. Almost looks like an inflammatory membrane.
We have another question.
Sure.
This comes from Bo Henson on YouTube,
Uh-huh.
and they responded, is this type of surgery the best for all OPLL or a different option?
Interesting question. Well, this is not surgery for OPLL. We would never do this surgery for OPLL. Thank God OPLL is extremely rare and we almost never see it. This is not OPLL. This is a herniated disc. Herniated disc, bulging disc, ruptured discs, protruding discs, extruded disc, bulging disc. Those are the conditions this surgery treats, and some bone spurs. But we are not doing OPLL surgery at all. That is for sure. Yeah. For those of you who don't know what OPLL is, it's ossification of the posterior longitudinal ligament. And the treatment for that is much different. It's, thank God, extremely rare condition. Most common in Asians. We've talked about it before on the program, and this is not the appropriate surgery for that condition. I don't see any more herniation here. I think we've gotten probably 80% of it, maybe more, but I'm not seeing any more herniation. I'm seeing the spinal cord underneath some fibers down there. So I think we've done everything we can do here. We're going to move on to the next disc and scope off.
Scope off, please. Thank you.
That was really good. We got a lot of herniation out. You can actually see a lot of it right here, you know, that's come out of the tube. You guys see all this right here?
Yep, we do.
I'll give that over to Luis. I'm going to use a little betadine antiseptic, topical antiseptic. And the idea here is to, you know, make sure we don't get an infection. Surgeons use topical antiseptics all the time. It means we inject it topically rather than in the vein or muscle or artery or anything like that. We just inject it straight on top. Any more questions?
No current questions.
All right. Let's go ahead and show the audience, why do patients with herniated discs have pain? Neck pain. Our fluoro in?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen.
All right, we had to interrupt the video because you got to see this x-ray. This is incredible. The retrolisthesis of 4-on-5 that we just operated on is back to normal alignment. So the alignment's fixed. The bones are lined up again. I've seen this happen with this surgery. I can't explain it, but it's an observation that I've seen every time we do this. All right, you can go back to playing the video while we get ready for the next level. Sorry.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. We're finished at C4-5. We still have to do C3-4 and C5-6, the disc above and below. So I'm about to take this thing out, and we're going to move it to the next disc. Shot? Yep. Here we go. I have to take it out of the disc, and I'm taking an x-ray picture as I do that. Shot. I feel the lip. I'm right there, and now I'm right there. I'm out. Let's get an AP. Let's figure out if I'm on the right or left of the spine. I want to be dead center. So before I go any further, I have to check. Oh, we're way off to my side, so we got to move back to the middle. Shot. Oh, now we're back in the middle, and I want to stay in the middle. Just shot. That's perfect. Now let's go lateral. That's why you have to use two views, folks. You won't know where you are unless you get the AP view. So this procedure requires intraoperative fluoroscopy of very high quality. Our fluoroscopic machines are the top of the line Siemens. Shot. So we're off probably again. I need to figure out where we are. AP. Shot. Come on. Quickie. This is not a setup. This is a quick shot. All right, so we're not bad. We're just a little bit off to the opposite side. Shot. 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 AP. It's not moving as easily as I normally have it move. Quick shot. Come on. All right. Hold on. Shot. Shot. I just think there's a bone spur there. That's good. Go to a lateral. Bone spurs in the front of the spine are not a concern. We're not here to fix those. They don't cause problems. Can you adjust the collimator so I'm not radiating my hand and fingers so much, please? Just a little bit would be nice. Shot. All right, so shot. I'm on top of the disc. Shot. I just need to check the AP view. Shot. That's it. Perfect. Lateral. So I'm in the middle of the spine where I want to be. There's just some adhesions, a little bit of adhesions in the front of these discs, and I can feel them. Shot. That's perfect. I want to anchor. Shot. All right, so I'm starting to anchor my dilator. Shot. Let's get an AP just to verify. You want to always check both views, AP lateral, before you commit too much. Shot. That's perfect. Let's go back to a lateral. So we're dead center where we want to be. And I'm going to advance the dilator, which is hollow, by the way, in the middle, to about the center of the disc, maybe a little bit past. Shot. Shot. And then I'm going to do a discogram, which is where we add that dye that we did before. And the reason we're doing the dye, shot, 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 getting close, shot. Yeah, I just want to clean out the center and get the junk out of there. We're going to do the dye so we can see the tear and we can see the herniation. So it guides my annular debridement and my removal of the herniation. Show them the herniated disc. Show them the tear right at the tip of the dilator there. You can see a big tear. It fans out as it goes back. Show them the herniation. See how the dye outlines the herniation? That shouldn't be there. All right. Come back to a lateral view. We're going to advance the dilator to the herniation. Shot. Shot. Oh, yeah. So there's a lot of pressure here. It's pushing my tool backwards. We see that when there's a lot of inflammation. That's it right there. All right. Very good. So we're inside the herniation. You can see that. Now we're going to go in with our tube and we're going to debulk the herniation, meaning taking it out from the inside. Yep. Now I want to watch my dilator carefully. Shot? Nope. Let's keep an eye on the tip of that dilator. Make sure it doesn't advance. You can see the tube going down. We're moving at about a millimeter or two up. See, that's why we have to keep an eye, because the pressure has pushed the dilator back, and we don't want that. We really need that dilator to be in proper position as we slide along the dilator, advancing the tube. Shot. That's why you have to frequently get x-rays and frequently adjust the tools, the instruments. By the way, for those of you wondering, this is all FDA approved. At Deuk Spine, we don't do anything that is not FDA approved. Perfect. We're inside the herniation. I may pull back a little bit, but right now I'm exactly where I want to be. So I'm allowing the herniation to go through the tube. Show them. It almost looks like it started already. Show them the end of the tube and the herniation on the x-ray. Can you stay on the x-ray, Henry?
Copy.
Jordan's going to bring the pointer in. And go ahead and show them, yeah, that's the end of the tube, and it's hollow. So we're going to basically suck out the pieces of the herniation using the laser to help us.
An angle on the seating.
All right, any questions from our audience?
Yes.
Thank you.
We have a question from Wanda Jones on Facebook.
Hi, Wanda. Welcome to our live stream.
Lights off, please. Thank you.
And Wanda asked, can a person have multiple tears in a disc, and how do you know which tear to do the DLDR on, or would you do it on all of the tears? All of the surgeries I've watched, I've only seen you go into one annular tear in each disc.
Hi, Wanda. Thank you. Yes, there's only one annular tear. It's at the back of the disc. That's the only tear we're interested in. There could also be a tear on the side. There could be a tear in the front. But those don't cause any problems for the patient at all. We never repair side or front tears, as they don't cause any symptoms. Great question.
Thank you. Appreciate it.
Only the tear in the back of the disc can cause a herniation that has symptoms. We are literally inside the herniation. That's pieces of the herniation right there. It's all stuck together. I'm fragmenting it or debulking it, breaking it up into little pieces. Now, as far as my reference points, I'm looking for where the annulus attaches to the end plates on the left and right, so I know exactly how deep I am, and I make sure I'm not going any deeper. This is all herniation here. And you can see from the gold color that there's calcium in it. It's not in the herniation itself, it's in the scar tissue associated with the herniation. Now, compare this to the last disc we did. This is all newer herniation. This looks to me like, except for the calcified part, this blue fluffy stuff right here, this is fresh. Oh, there's a piece that just came out. Look at that. So yeah, that's a fresh herniation. It looks like it's probably a few months old. By the way, this is a wonderful way to age herniations. There's no other technique in the world that allows you to age a herniated disc except to be inside of it, looking at it. And with all the experience we have at Deuk Spine, we know how old these herniations are based on the calcium pattern right there you're seeing as it interacts with the laser. The amount of scar tissue we can see. You can't see any of this stuff with an MRI. You can't see any of it with a CAT scan or a discogram. The endoscopic is the only surgery, the only test in the world that tells you how old the herniation really is. And you can't match it to the exact day, but you can break it down, and usually within a few months. So for people that have had auto injuries, for example, and you want to know, is my herniation, timing of the herniation around the time of the accident, I could do that with all the experience we have. A lot of people always want to know, when did my herniation happen? Well, this is the best way to tell. All right, any other questions?
No current questions.
Wonderful. So this, yeah, there's definitely a lot of herniation here. We saw all of this on the MRI, the amount of herniation. We just can't really tell all the details until you actually get in and start operating. But this is all herniated disc here. And it's significant. Let's run our video on how does the Deuk laser disc repair actually work.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. Welcome back. All right, we are moving along beautifully. This disc is very different looking than the last one. Again, this is C5-C6, the most common disc to herniate and be symptomatic. And one we did before was C4-5. And the C4-5 was by far the worst and the oldest. You could tell it was more collapsed. And by the way, if you weren't paying attention, I'll tell you, we were able to fix the alignment of C4-5 with the lasers. There's a herniation right there. Look how big that thing is. It is a monster. Remember, the inside of this tube is about almost 4 millimeters. The outside is 4 millimeters. The inside's about 3.2. 3.3. And this is another big fresh herniation. This thing has happened recently. I'm not going to bother to cut to it on the camera. You've already seen enough herniations today, and we're just going to keep going. Remember, our patient is asleep under general endotracheal anesthesia. She's completely out of it. She has the best anesthesiologist in the world for this case, Dr. Berndez. And I remember when Dr. Berndez started here, the first time he watched these surgeries, I think he was really realized he was part of something special. Right, Dr. Berndez? Yeah. I had to recruit Dr. Berndez from the West Coast of the United States. He was busy doing working in a facility out there, and fortunately I heard about him, and his reputation preceded him, and I had to recruit him, and here he is. Right? How do you like the area? He likes. Whole family likes it. Good. He left Sin City. 23 years. You were there 23 years? Here's another big herniation. Well, this disc I don't think is going to take us quite as long as the last one. And you can see how the laser jiggles out the herniated pieces. They just keep coming out of the foramen over there. See that? Just more and more pieces. And I don't even have to do anything but put the pulsatile, pulse wave on them. That's all part of the annular tear right there. And I'm debriding it. It wants to heal, but it can't because the herniation is in there. Are we back live?
Yeah, we've been back.
Oh, okay. See the herniations coming out of there? All right. There's the tear. So yeah, somebody asked about where the location of the annular tear. It's always in the same place. It's the back of the disc, and it always looks the same. I mean, it's a giant tear across the back of the disc. Sometimes it's smaller, sometimes it's bigger, but the location is pretty much always the same. The story is the same. That's the tear right there. You see how the annulus here, the white stuff, is separated off the bottom of the bone? It literally is ripped off the bottom of the vertebral body end plate. We call that the end plate of the vertebral body. And it's separated. That's trauma, okay? That's a traumatic event happened at some point in her past that ripped that annulus right off, sheared it off the bone. Kind of like when you're eating, lamb chops and you pull them apart with your fingers. You're ripping those same things, those same kind of tendons and ligaments, and they just pull right off the bone, okay? It's the same thing. She did something in her past, and it wasn't eating lamb chops, but she did something to traumatize this disc, and that's caused all this herniation to be allowed to escape. The problem is most doctors don't understand any of this. They don't get it, so they don't understand how to fix it because they don't understand the condition itself. They're living in the past, in all these disinformation and lack of information, lack of knowledge and understanding about it. And unfortunately, patients pay the price because if their doctors don't understand it, how can the doctor tell the patient about it? So I've been trying to teach physicians now for years about the annular tears, herniations, how we can repair them now and get rid of pain in the neck and back. But unfortunately, a lot of doctors still don't listen. So they're very set in their ways, dogmatic about their beliefs, not really open-minded. And honestly, I I was guilty of the same thing before I started doing these surgeries. Because that's what I was taught. This is all scar tissue from inflammation. All the golden, thick, whitish gold stuff that we're zapping away.
And that can be dated longer than a year.
Oh, it's way more than a year. Yeah. So there's parts of the herniation that are well under a year, and you can see those. And they're little fluffy, light pieces of herniated nucleus. And then there's parts that are older. Like the annular tear has been around a long time, you can tell. So you can kind of see through the posterior ligament right there, the spinal cord, just underneath. I don't see any more herniation there. That's out the foramen right there. I don't see anything pressing on the nerve root. I'm just cleaning up a little scar tissue here. I may want to get a better look right here, but those look like fibers of the posterior ligament, posterior longitudinal ligament running behind the vertebral body, and I don't really see much. That's my laser tip we're going to have to go get out. Grab her. We're going to need to restrip the laser tip.
Can I have a stripper, please? Lights on, please. Thank you.
So let me look at this disc again on the MRI.
Let me see. What's the size? What's the size? 5.0? No, I need the 5.0.
We're going to have to restrip the laser. I'm going to go take a peek at the MRI one more time while we're restripping our laser and getting it ready to go back to work. Okay, so there you go. I'm looking at this MRI, and this disc in particular is does not have a lot of herniation behind the posterior ligament. Keep scrolling. Yeah, so I think we've gotten all the herniation at this point. I think we're pretty much done. I'm just going to look around one more time, but I think we're done here. And then we're going to move on to the last disc, which is the number 3-4. So the biggest herniation was at 4-5. We've already done that one. The next biggest herniation is at 3-4. The smallest of the herniation is at the disc we're at right now. Any questions from our audience?
No current questions.
So far, everything's going really well for her. Scope on. Good. You can see we got that little piece out. Hold on. We're going to reload the laser. Let's show our audience the laser real quick. Can you guys see this?
We can now, yep.
Can you see how skinny that is? So the actual fiber is glass. It's at the tip. I don't know if you guys can appreciate that. And it has a little red targeting beam. That's visible light, obviously. It's not the laser. But the glass tip is just 0.5 millimeter. And here, hold this. We're going to put that down this channel right here. It's called a working channel. Go ahead, Luis. You take it and do it. I'm letting Luis fix it. And we're going to go back in. I'm going to look around one more time, and we're pretty much done at this disc. We're going to move to the last disc that needs to be fixed, which is the second worst disc after the number 4-5, which we did first. All right? I think I need to flip it and look towards you. So I'm very happy so far with everything. I think she's going to be very pleased with the results of the surgery. Yeah, I need to clean this side. More pieces of herniation.
We have a question.
Sure.
This comes from Wanda Jones on Facebook once more.
Hi, Wanda. Sure.
And she asked, I had the free MRI review, but my MRI was 10 months old. Do you do a new MRI before each surgery so you know you have the most current MRI? And thank you for the free MRI review.
Oh, sure. Hi, Wanda. You are welcome, of course. We love helping people figure out what's wrong and giving them guidance. So, no, we don't need a new MRI if your MRI is So here's the thing. If your MRI is 18 months old or younger, then it's fine to use, unless you have had new symptoms. Like if you have, let's say your MRI is a year old that we review, and then you had 3 weeks ago, you got a lot worse, right? Your symptoms got a lot worse. Then we're definitely going to want a new MRI because your symptoms got a lot worse. So you probably have something going on in there, right? We need to see what it is. But aside from that, most people don't have that happen, where their symptoms get worse that suddenly. Then the 18-month or younger MRI is fine. We don't need to order more. We're not interested in raising costs of healthcare. We're interested in lowering the cost of healthcare. We want to save money for everybody, and this surgery does that, because with fusions you have a lot of complications. They cost money, a lot of money, and they hurt people, and they keep people from going back to work and doing the things they're supposed to do. Fusions are very expensive and pretty much unnecessary, I say 98% of the time. But that comes from a surgeon, by the way, who's done over 1,000 cervical fusions and 1,000 lower back fusions. I've even published on fusions as one of the leaders in the world in lumbar fusions. So it's not like I don't know what I'm talking about. That said, the MRI should be fine as long as it's under a year and a half old. All right, we're pretty much done. I'm not really seeing much and more. This is that foramen at C5-6 on the left. We've gotten most of the stuff out. I'm just gonna spend another minute here and we're done with this one. Yeah. Yep. Looking good. Looking good. Let me just peek the other way real quick. Sometimes you'll get a herniation that sneaks in there, like that one. I don't see anything more. We're done at this level. So coming out with the scope.
Scope off, lights on, please. Thank you.
I'm going to put some antiseptic in again. And again, we've never had an infection with this surgery. It's very minimally invasive. There's no hardware being left in. It's a very quick surgery. So the kind of things that predispose you to infections from spine surgery or any surgery is, number one, the equipment is not sterilely processed properly. So I need some more irrigation. So basically, that relies on the sterilizer of the facility. We have the best sterilizer made in the world. It's called a BellyMed. It's an orthopedic sterilizer. It's special. Wouldn't you agree, Luis? We have two of them. Yes, two of the best in the world. And they do a great job. We've never had an infection here with those sterilizers, ever. The other thing is the length of the surgery, like how long it takes. So of course, fusions take a lot longer, right? So they're higher risk for getting infection. And then no metal, no implants, right? So when you put implants in a patient, they can trap bacteria on the implant and raise the risk of infection. So we're not putting any implants. We're not putting a metal disc or a metal cage or a metal plate and screws. So the risk of infection goes down because we're not using any implants or biologicals. And then, bleeding. If you get a blood clot where you do the surgery down inside, that increases the chance of infection. So there is no bleeding, as you can see, and there's no blood clots. Alrighty then. Beautiful. Here we go. We're going to go all the way up to the top. So I'm going to start by removing my tube, leaving the dilator shot. Want to keep an eye on it, make sure I don't pull out or push in. Who is that? Oh.
Huh?
You had me worried there. Thought the patient was moving, but she's not. Shot? All right, perfect. So 2, 3, 4, 5, 6. We are at 5, 6. We're going to make our way up north. Wait. Shot. Yep, nicely done. Come out. I feel I'm on the lip. And hold on. I'm out. I'm out. Good. All right, now we're going to get an AP and see if I've slid to the side. The reason why you need to get an AP is the esophagus and trachea are pushing me to the side. And so I've got to make sure that they haven't pushed me too much. There we are. We're still in the middle. So go back to a lateral. I'm going to keep moving north. We call north towards the head. North. Nice. So I've got to go past this next disc, which is shot. That's the number 4-5. I can feel it. Let's get another AP to make sure you're pulsing, right?
Yes, sir.
When we pulse with fluoro, we're reducing the amount of radiation we're using. We're using it at a bare minimum. And, you know, X-rays are radiation, and we need X-rays to do spine surgery. It's not possible to do it without X-rays. So for everyone's safety in the room, the staff, the patients, we want to minimize the amount of radiation. And again, that's another benefit of Deuk laser disc repair. We use a lot less radiation with our surgery shot than, say, a fusion does, because fusions, you have to use a lot of radiation while you're putting all the screws in. Shot. All right. It's keeping us right in the midline. Go ahead. I'm sliding down the slide. So if you've done spine surgery in the cervical spine through the front, you know that there's two muscles called the longus colli muscles, and there's between them the anterior ligament, anterior longitudinal ligament. That's what I'm sliding along. It's nice and slick, and I can feel it. Shot. And the muscles are kind of keeping me in like a railroad track, keeping me in the middle. So I'm hoping I'm still in the middle. I'll do another X-ray. Okay, that's good. I'm a little bit off to Luis's side, but I'll come back. Stay there. Right there. Shot. That looks good. Back to a lateral. So I'm dead center where I want to be. And you have a little bit of leeway. You can be off maybe 5 millimeters, you know, to the left or right of the midline. You're fine. All right. Just about done. We're going to go a little bit further. Shot. That's perfect. Now I need an AP. The lateral looks good. I got to do an AP. Now C3-4, what we're about to do is a hard disc to get to. It is not easy. Shot. See, I'm a little too much to my side. How's that? That looks good. Let's go back to a lateral. So you got to make corrections as you're doing this kind of surgery, because if you don't, you're going to end up hurting the patient badly and you'll have a bad complication. And then you got to blame the anesthesiologist. I'm joking. Shot. Little taps. Shot. All right, let's get an AP. Every one of these little pictures I take is important to do, because it makes sure that you're attacking the disc in the right place. Yep, that's perfect. We're right in the middle. So now that I've started the tip going through the anterior disc annulus, I want to verify I'm in the right place. Okay? So now that we're starting to go through the annulus, I'm going to keep going. Little taps, little checks. Realignment, shot. Now we're in the middle. Starting to feel the jelly, shot. And I can actually feel it, shot. That's good. So we're going to go ahead, get the jelly out of the middle of the dilator before we do a discogram. Shot. Yeah, there's a bit of resistance. You feel that? Shot. Luis, with the...
With the gut, yes, yes.
May have to
Straight
straighten it out or get rid of it. It's good to know I can still get it in the hole. Shot. All right. Listen, I'm allowed to say that because that's truly what I'm doing. Oh, show them the tear and the herniation. So we're going to show you right now the tear, yep. The little black line there, and then the herniation. Yes, very good. Very good. Shot. Yep, so I'm going to realign. That looks pretty good. I feel pressured. I feel like the disc is kind of pushing me out too. By the way, you see this tube here, folks? That's what we do the entire endoscopic surgery through, this same tube. It's only 4 millimeters. Honestly, if you ask most spine surgeons to watch this surgery, their reaction at the end, if you were to ask them, was the surgery you just watched more believable than alien aircraft landing in your backyard? They would take the alien aircraft landing in their backyard as a video as being more believable than this. That's how they've never seen anything like this before, okay? And then if you say, well, which is more believable, this surgery that it's actually happening today in the world or the Loch Ness Monster? And they would choose the Loch Ness Monster. Because when I first watched this surgery, I have to be honest, that was 18 years ago, no, 16, 17 years ago. I didn't believe it. As a very well-trained neurosurgeon, I said, that's not possible. That was the first thing my mind said. That's insane. I've never seen anything like that. And of course, I trained at the University of Florida in Gainesville, which, if you understand anything about neurosurgical training, back in the 90s, that was the best neurosurgery program in the country. So, being trained at the best and never seeing this procedure shot at my institution while I trained with the best neurosurgeons, I was like, this can't be real. And it's too much to believe. This is like a movie or something. This is fake. But it was real. And I went and learned it from the Koreans who were doing it in South Korea, and a German surgeon, Dr. Stefan Hellinger. I learned the actual technique, the putting the tubes in. Then, of course, over the years, I modified what I did and developed the specific procedure we do today called the Deuk laser disc repair. But in the beginning, I did the standard endoscopic anterior transdiscal approach. Almost there. I'm moving at about a 0.5 millimeter a tap. That's perfect. Take that. I got it? All right, so one more shot, that's perfect. And you can see we're at C3-4, right? So we've done number 4-5 and 5-6. Now we're at 3-4. Now she does still have some bone spurs. You can see them, but we're not here to take all the bone spurs out. We're here to remove the herniation and decompress the spinal cord. We do remove bone spurs when it's necessary, but a lot of bone spurs are off to the sides where they're not causing any neural compression or symptoms, so we don't mess with them. We only treat symptomatic bone spurs. All right, there's a herniation already. You see the herniated nucleus pulposus there? That is a piece of herniation. So far, looking at that, I would say this disc herniation will be a newer one as well. So I think the oldest one is C4-5. The newer ones are C3-4 and C5-6. Again, you see the smoothness of the herniation. That's from the inflammation. So it's sitting right on the war zone, and it's getting bombarded with inflammatory material. Oh, there's another. See the smoothness of the herniation, that smooth part? Once again, from inflammation. So that ages the herniation right there. I don't think I got it. All right. Any questions from our audience, Henry?
Yes. We have a question from SPX730 on YouTube.
Hello, SPX 730.
And they asked, wow, is this actually live?
Yes, it's live. SPX 730. Watch, I'll jiggle my laser around for you, SPX 730. Pretty cool, huh? I always wonder the same thing when I'm talking to beautiful women online. Are you real? Yeah, this is live. We've been broadcasting live for almost 10 years now from this facility every single week almost that I'm here. I know it's hard to believe, but we believe in educating the public. And, you know, yes, it's cool to watch live surgery, but it's also good to get your questions answered and learn, you know, whatever you can about spine if that's what you're interested in. So this is the tear. You can see the blue stuff right there is the nuclear material that's staining with the dye, the blue dye, the Deuk spine dye that we use. But that's the tear right there. I mean, we just went right through it. We debrided it. So this is the annular debridement part of the Deuk laser disc repair. Now, for those of you who are joining us for the first time, these surgeries are done so we can avoid fusion. Everyone's told they need fusion or artificial disc, but they don't. This is the next generation. This is the most advanced spine surgery in the world. And we're doing it right here in the Space Coast of Florida. We've been doing it for 16 years. People come from all over the world to have this surgery done. All right, the laser fiber is at 12 o'clock. It's the glass-looking thing. Just remember the width of that is 0.5 millimeter. There's another herniation coming out. You see that? It happens quick. And the reason it happens quick is it's moving at the speed of the impulse from the laser. So the laser, you can't see it, but it's delivering laser energy and it's oh, there's another herniation. Just came out right there. So you see how many herniations there are just at this one disc? There's the crack where the herniations went out. My job is to go in there and get rid of them. There's another one. And what I'm doing for those of you is I'm coming out the tube. So I'm creating a place for the herniation to escape to the top of the tube. If you look at the operating field, I have all these pieces of herniated disc right at the tube exit. So that's where they dump out. There's another piece. They just keep coming. Now I'm not cutting these. I'm just releasing them, freeing them up. And here they come. You see there was another one that zipped by us. So the thing about laser energy is it's invisible to the eye. The human eye cannot see it, but believe me, it's there. And I know what you're seeing the reaction of the tissue to the laser, but understand this laser can melt steel, and it can and it does, as a matter of fact, melt steel. If you look at my tube at the bottom, you may actually see some of the melted steel. We call them blast marks. Yeah, I'll show it to you right there. See the blast marks right there? That's the steel is melted from this laser. And by the way, the setting I have it on is 20, and it goes up to 100. So that's melting steel at like almost the lowest setting. Okay, so that just gives you an idea of how powerful. So trust me, if this laser can melt steel, it's going to get rid of bone spurs that we want it to get rid of. Can do a lot of damage too if we're not careful. So that's why I have to control it carefully. Most of the surgery is called an annular debridement, It was first described by us at Deuk Spine Institute. We were the pioneers of this technology. And the annular debridement is the most important part of this surgery. It's what I spend 95% of the surgery doing. And it's unique to the Deuk laser disc repair. Some people want to know if this is FDA approved. The answer is yes. Everything we use is FDA approved. This is happening in the United States. All right. We are halfway done with this disc, doctor. We've got 10 minutes left. Just sharing with my anesthesiologist so he can start planning to wake the patient up. Whenever you're doing surgery on a patient, you always want to keep them under anesthesia for as short a time as you can and use as little medicine as you can. That's just what they need. The more medicine you use, the more their body has to metabolize it, and that takes time. Stubborn. How's my irrigation? All right. It's fine. I was just trying to float that guy out. It was taking a while. All right. Any other questions?
No current questions, but we have a comment from SPX730 once more, and he said, amazing content, guys.
Oh, thank you. Yeah, you know, unfortunately, SPX, I can't get the same views as girls in bikinis yet. But honestly, I think I deserve it. You don't want to see me in a bikini, trust me. Yeah, it's, I'm glad that people appreciate what we're doing. It's hard, you know, getting the word out there because, let's face it, there's a lot more attractive content for people to spend their time, you know, viewing. But we think there's a place for this for people who want to learn and want to know that there's a way to get out of pain, really. I think there's a lot more people suffering with neck and back pain than there is beautiful Instagram models. So there should be a lot of interest in watching these surgeries and learning. And that's why we broadcast, is for educational purposes. We don't get any money for doing it. But at the same time, I am operating here for an hour and a half, and honestly, I don't want to sound the wrong way, but it gets pretty monotonous doing the same thing. That's what surgery is. It's pretty monotonous. And the nice thing is that when you figure it out how to do the procedure just right, you do it the same way every time. You don't have any deviations. And then you can actually kind of, I hate to say it, relax a little bit while you're doing it to where it's not so stressful. And then I can focus on teaching. So I enjoy the teaching aspect of this, where I can actually explain what I'm doing and why I'm doing it. And my whole team likes teaching. How are we doing, guys? I think 3 minutes. So because we've got the time, I've got an hour basically standing around just using my hands and part of my brain. I want to put the rest of my brain and my mouth to work. So it's kind of killing two birds with one stone, if you will, where I can help people at the same time as I'm operating and share something special with them that they can actually see and appreciate. This kind of view is usually reserved only for surgeons in training. It's hidden from the rest of the world, but I find it quite interesting. This is how I learned. I learned how to do surgery by watching another surgeon doing it. Every surgeon learns surgery by watching another surgeon do the surgery. So why not share that experience with the rest of the world? Not that you guys are all going to become surgeons, but there's a lot of interest in the public's part on what happens in the operating room. You know, what are you guys doing in there? And so got the idea of just letting people come in, you know, and sharing the experience with us. This way you guys can watch and learn and ask questions. I have nothing to hide. I'm very confident in our skills and confident in our outcomes. Doesn't mean it's perfect every time, but, you know, we're human and we do the best we can. And generally we have really good results. So there's a big herniation right there. So it affords everyone an opportunity to see what exactly we do, but at the same time for me to teach and answer questions. That's a more scarred up piece of herniation right there.
We have another question.
Sure.
This comes from SPX 730 once more. And they ask, what's the estimate chance for hernia relapse after this procedure?
Yeah. So what you're asking is what's the, we call reherniation rate, and it happens to be known. It is 1%. 1 in every 100 of these patients will have another herniation right where I did the surgery. And that's a big herniation, by the way. And what I found is that it's almost always related to them not following my instructions afterwards. But, you know, people will be people. I think there's more than 1% that don't follow my instructions. And the instructions are simple. It's really no lifting over 25 pounds for 6 weeks. And after 6 weeks, you can go to 40 pounds of lifting. 40 pounds for 1 year. And I think what happens, typically what I hear from the patients that reherniate is that they were feeling really good and they thought they were fine. But just because you feel good doesn't mean the disc is healed. You know, that's something that you can't speed up. So there's another big piece of herniation. I'm going to try to grab that out. Yep. Huh? What? Oh, you're not talking to me?
Scope on, please.
Which way was I facing?
Like that.
All right. Hold on. Don't move that, please. I couldn't get that herniation. Let me see. The fluid adapter came off. I'm just going to have to take it out a little bit at a time.
We have another question.
Sure, yeah.
This comes from Joseph Chavez on Facebook.
Uh-huh.
And he asked, how do you know where to go in and operate from looking at an MRI?
Yeah, Joseph, great question. How do I know where to go and operate from looking at an MRI? I don't. That's the answer, I don't. You cannot tell where to operate on somebody just based on an MRI. You must do a physical exam. The physical exam is so important, and that's what a lot of doctors don't do. They don't do the physical exam. I cannot do it based on just an MRI. We have an MRI review service that we offer for free where we can figure out what's wrong with people, but you'll see that I don't just use the MRI. I actually do a physical exam using Zoom. So it's not possible to do with just the MRI. Now that said, I use a combination of the MRI and the physical exam, both. And by using both, I'm able to figure it out. How do I do that? Well, that's the art of what I do. That would be like asking a Japanese samurai sword master, maker, how does he make the sword so perfect? And there's technique that he has or she has, and you have to figure it out over the many years that you do it, and you follow that process over and over again to make sure it's done right every time. 3 minutes probably. So I'm like, in a way, I've developed a technique that's worked very well for making the diagnosis. Is my irrigation okay? All right. No, that's fine. I hear the suction. I'm just looking at the floatability of disc material. Seems to be dropping off, but I think we're okay. So once again, it's not just an MRI. You cannot make a decision based just on an MRI. If you do, you'll be wrong. You'll be wrong more than 50% of the time. And you'll be doing things you shouldn't be doing for the patient. And it'll be unnecessary treatments you don't want to do. For me, it's very important that what I do works for the patient to help them. And that's why I stopped doing what all the other surgeons were doing, because what they do doesn't work. Let's face it, how many times have you heard horror stories from back surgery or neck surgery? Those horror stories are the standard. That's typical. That's what most surgeons have as their results. That wasn't good enough for me. I had to understand why the results weren't better and how I can make it better. Wow, I feel something. The muscle relaxer must be completely worn off. Stand by. Because I'm feeling with the laser, the nerve is being activated. It's not doing any damage, but it's just being activated. That's fine. No, I don't want you to do anything different. Literally, I'm just getting the last few pieces out and we're done. I just want to feel good about this foramen over here. Why do we have so much suction noise, by the way?
It's right here. There you go.
Can we stop that, please?
Can we stop the sucking right here? This one right here, the bag. Only the bag, please. Yeah.
Is that really the bag making all that noise?
Yeah. It's right here. Thank you.
Man, it's like the disc herniation just doesn't want to stop coming.
I still hear it.
Any more questions?
No current questions.
All right, so listen, we're literally going to wrap this up in the next few minutes. And I would encourage you people to type up some more questions if you'd like, and I'll be happy to answer them face-to-face with you. I'll be over in the broadcast room in about, 10 minutes. So type up your questions and then stick around for the answers if you'd like. Or come back and watch it later. We broadcast our surgeries live on YouTube, Facebook, Twitter, LinkedIn. Am I missing anything, Henry?
Repeat that once more. Repeat that once more.
We broadcast live on Facebook, Twitter, LinkedIn.
LinkedIn, Twitter, Facebook, and our YouTube. Yes.
So now that we've cleaned out the herniation and debrided the annular tear, this disc will be able to heal naturally. It doesn't need fusion. Okay? So the only reason why doctors do fusion is because when they're doing this surgery, they literally have to take the whole disc out because they don't know how to do it endoscopically. So the endoscopic part of the surgery is what allows me, I'm going to just look the other way and we'll be done, is what allows me to not have to take the whole disc out. When you don't have to take the whole disc out, you don't have to fuse. You don't have to put an artificial disc. That's it. Okay, we're done.
Lights on, stop off, please. Thank you.
Let's go ahead and show the audience just the incision real quick. Oh, can you see this here, Henry?
Yes, we can see it.
Lots of little pieces, right?
Yes.
a lot of like herniation dust. And I'm going to show you the incision. This is a little antiseptic. Make sure we don't get any infections. Take this, please. Irrigation. That's a betadine is what it is. And betadine was developed by NASA as an antiseptic. I think we're good, Luis. Yeah. Done. I'm going to show you real quick, folks, the actual incision and tube. It's quite literally 4 millimeters. Can you see this here? Fluid adapter. Can you see this, Henry? Is it too dark? Henry? All right.
I was talking to
Can you
Ron.
see the tube coming out?
Yes, we could see it.
Great. Taking it out, put a little bit of pressure for a few minutes, and then we'll be done. Now we've lost about maybe 5 drops, 6 drops of blood, and if you 20 drops of blood make 1 milliliter, ml, which is 1,000th of a liter, 1,000 milliliters make a liter. We lost 25% of 1,000th of a milliliter. A milliliter. All right, let's take a look at the incision. Okay, here it is. You see that? That's it. We haven't done any damage to anything else underneath the skin. The skin cut of 4 millimeters is the only thing we've done. Everything else has been spread open. So if you do open surgery, the surgeon's going to rip apart all your muscles and tendons and ligaments and blood vessels inside. You won't see it, but you'll feel it. That's why these patients that have the Deuk laser disc repair, they don't need narcotic painkillers after surgery. We do Tylenol, an anti-inflammatory for one night, and a muscle relaxer for one night usually. But if you have open surgery, whether it's an artificial disc or an ACDF, all that pain you're having is from them damaging your body during the surgery. This patient won't have that. There's no bodily damage done during this surgery. It's endoscopic, it's minimally invasive. It's the least damaging surgery there is in the world. All right, we're going to show you a comparison of fusion, an open surgery, versus the Deuk laser disc repair. Then I'll answer your questions.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk here at the Deuk Spine Institute. I'm with one of my patients who's traveled to us from Mississippi. And he came here for the Deuk laser disc repair to be done for a herniated disc on his neck. And he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well, no problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything is gone. A little soreness in my throat. My voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4mm incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery and I decided to give it a try. And I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck, on your spine.
No, I think the cold weather would have had an effect on it. I think it would have caused an adjacent effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
This is Dr. Deuk. I'm here with one of my patients who underwent the Deuk laser disc repair on his neck just yesterday. How you feeling?
I'm feeling better, a lot better. Already, after years of chronic neck pain, I'm already feeling better within 24 hours.
So is the pain that you had when you came here, do you still have that pain?
Not that pain, it's just, I think, a little bit from the surgery itself, but it seems like a lot of the numbness and the tingling in my hands went away, and already starting to feel a lot better.
Now you had a fusion done before, not by me, and you can see the scar there. And then you had the laser surgery done yesterday. And how would you compare the two experiences?
Night and day. I actually, when I had the fusion, had to go back to the hospital with complications. And it just took a long time to recover from that. So this was much, much better.
Your fusion on your neck was done by a pretty famous neurosurgeon, right?
Correct.
Even with him doing it, there were still issues.
Yes.
What kind of problems did you have with the fusion?
Well, I went there for the numbness in the hand and still the chronic pain that I've had for many, many years. And it seemed to take away the numbness in my hand, but the pain was still there. So I spent many, many years going to chiropractors. I've had injections, I've had massage therapy, physical therapy, and it, most of them gave a little bit of relief.
Did any of them get rid of your pain?
Not completely, no. Just kind of made it bearable.
And is your pain gone now?
it's certainly getting there. I'm thinking probably within a week it'll all be gone.
And your surgery was done, even though you had a metal plate in your neck from your prior fusion, we were able to work around the plate and get in there and fix those discs, especially the C3-4, which was, you can see a lot of herniated disc material in there that was causing most of your symptoms. So I'm happy you're doing so well. And you had it outpatient, so you didn't even have to go to the hospital.
Correct. Yeah. Left in about an hour and a half.
What are you going to do now that we fixed your neck?
Well, I'm going to take care of it for the prescribed 6 weeks, and then hopefully I can start getting back to a normal life, be able to get back to golf and things I like to do. Dr. Deuk and his processes here and everything's amazing. If you have a lot of chronic neck pain or back pain, I would highly suggest coming to him.
Awesome. All right, my friend. Congratulations. It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March, and I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did
he did a
Googling.
lot of research, and we found Dr. Deuk to be a man of integrity. He films all of his surgeries. He puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
before
correct.
Surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the
Yeah,
way up.
just the next day,
You
right
couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, 2 of them, C4-5, C5-6, and the herniations were literally sitting on the nerve, and we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the frame and where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny, and here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees, and
nice.
then they woke up to about 11 degrees.
So the cold front came in. We get those from time to time, and it gets cold around 60 degrees. Well, most of the time it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Deuk will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So go for it.
I said that it was so important that I said I'd pay for it. You know, because
you know, we got a little bit of a nest egg, and sure, it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you
yeah.
pass away.
All right, folks, we'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake.
One.
Hi, Dr. Deuk joining you after completing a anterior cervical Deuk laser disc repair. The Deuk laser disc repair is a type of surgery done. It's done to treat what we call symptomatic, meaning causing symptoms, symptomatic disc disease. And by disc, what we're talking about, just so you understand, is the disc or cushion between bones in your spine. And these bones are called vertebral bodies. The vertebral body is this big part right here. It's part of something called the vertebrae. The vertebrae actually includes more than the vertebral body. It includes the pedicles, the facets, the lamina, and the spinous process. So altogether, that unit is called the vertebrae. And the vertebrae are basically stacked on top of each other all the way up to your skull, all the way down to your tailbone, and we call that the spinal column. Now, because we're not stiff, we have joints in our spine that allow movement. The joint that allows the most movement is the disc, and there's another type of joint in the back called the facet joint. So today we operated on 3 discs, and this patient had a tear in the back of her 3 discs, and that tear, called an annular tear, allowed the jelly to push out through the tear. The jelly that was in the center of the disc pushed out in pieces, and we saw just how many pieces it can push out in. So most herniations are about 10 to 20 pieces of herniation, and those pieces happen over time. So today you may push out 1 piece, and a week from now a second piece, and then a month from now another piece, and over time you collectively get more and more herniations that cause inflammation, which causes symptoms like neck pain, headaches, pain down the arms, shoulders. Those are the symptoms of a herniated disc. They come from inflammation. They come from the annular tear that is inflamed, causing pain. Now, that inflammation can get onto the covering right behind the disc called the dura, and that dura runs up around your head, so you can get a headache if the dura gets inflamed. You can also get arm pain if the dura of the nerve roots goes down and gets inflamed. So the neck pain comes from the back of the disc tear. The headaches come from involvement of the dura going up around your brain. The arm symptoms, pain, comes from the dura around the nerve roots called the dorsal root ganglia, which are right behind the disc, and that irritates that dura and therefore irritates the dorsal root ganglia. Now, symptoms of weakness, numbness, and tingling, those 3, weakness, numbness, tingling, come from pressure on the nerve root, not inflammation or irritation, but pressure. So if somebody has just neck pain, pain down the arm, they have inflammatory irritation of the dura and pain in the back of the disc causing the neck pain, inflammatory irritation of the dura causing arm pain, and then inflammatory irritation of the dura causing headaches. If they have weakness, numbness, tingling in their arm or leg, they have pressure on the nerve root. So today our patient had both. She had pressure on the nerve root, she had inflammatory pain, and she had pressure on her spinal cord. So she had actually 3, the triple crown. Pressure on the spinal cord causes balance difficulty, it causes urinary urgency and incontinence. And yeah, so the surgery was very successful. We did it all through 1 little 4mm incision right here in the front of her neck. You saw that. Her face was covered with a drape. Her chest was covered with a drape. Just the neck was exposed. It's pretty standard stuff for neurosurgery, spine surgery. And we went in, and honestly, most spine surgeons, they go and take the whole disc out just to get to the back part where the herniation is. But the Koreans discovered that, hey, if you go through the disc, leave it alone, just get to the back part with the tube and then remove the herniation with the tube, you could leave the disc alone and you don't need to do an artificial disc or a fusion. So I went and learned that technique from them about 16 years ago, brought it back to the United States, and over time realized I was doing it different than them and that it was better results, better outcomes, and we called it the Deuk laser disc repair. So I put it all together and published it 10 years ago in the National Library of Medicine. It's indexed, it's published in Surgical Neurology International, and published in other places now in books and chapters. And anyway, long story short, here we are. I've now done over 1,500 endoscopic surgeries, cervical, thoracic, lumbar, most of them lumbar, and we've had great results with patients, the best results. Do we have any questions?
Yes. We have another question from SPX730 on YouTube.
Hi, SPX730 on YouTube. Yes, we are live streaming.
And they asked a question, is there a small chance to poke into something important with the endoscopic tube?
So great question from SPX. Is there a chance of, when you're putting that tube in, that you can poke into something and damage it? There is always a chance, absolutely. And that's why, I take all these steps that you watch me take, like taking the x-ray from the front, then taking it from the side. And originally we used the needle to get into the disc. Remember that? That was key. You have to do that. And then you put a guide wire down the needle, get rid of the needle, then you just use the dilator to go down. So as long as you place the needle properly in the beginning, you're not going to poke into anything. That's the whole point of the guide wire. It's like a road map. It tells you exactly where to go. It doesn't let you go off to the sides because it's metal. So it holds you in a straight line going into the right place. So there's a lot of technical details incorporated into the procedure that prevent causing complications. Think about it. 1,500 surgeries and counting. I stopped counting pretty much. And we've never had a surgical complication. That's never heard of before in the history of medicine. You cannot have a spine procedure. We've never had a spinal procedure ever where it's been done for 16 years or even 1 year of procedures, hundreds of them, and no complications. So it's remarkable. It's a testament to how safe this surgery really is when it's done properly. Now I kind of make it look a little easy. When I started doing these surgeries 16 years ago, I was sweating bullets. Let's face it. I mean, it was scary. Because anytime you start doing a newer procedure, it's pretty nerve-wracking, to be honest, because the risk is so high and the patient would pay the price. And they were aware, I made them aware it's a newer technology. They understood the risk. I went through all the risks with them and never had a complication with the surgery. So here we are 16 years later, after 1,500, I could say the same thing. No complications to date with the surgery. So it's a very safe surgery, but doctors have to learn how to do it right. And that requires training. The training necessary for the surgery is about a year's worth of training, 12 months, okay? Could some doctor learn it sooner than 12 months? Possibly. It depends on their skill and their background and how experienced they are and how knowledgeable they are about anatomy, how capable they are. So there's a lot of variables that factor in. And then there's always doctors that will never get it. And they could try doing it for years and they'll never get it. And there's a lot of them like that. So it takes a special kind of surgeon to be able to do this kind of surgery with the right personality, the confidence, the background, the training, et cetera, et cetera, et cetera. But I wouldn't let just anybody do it. It's not like you watch a video and you can do it, okay? Next question.
Next question we come from Wanda Jones on Facebook. And she asked, this is a good question. It seems that a herniation happens quite easily. After DLDR, wouldn't another herniation just occur in that same annular tear since the tear is still there after surgery?
Yeah, Wanda, great point. You are correct. So Wanda's saying, okay, well, Dr. Deuk, you made the point that first there's a tear, so there's a gap, an opening, a rip in the fabric of the back of the disc, the wall of the disc. And then just lifting something or doing some kind of torquing of your head like that will put pressure on the jelly. It's going to push the jelly out through the tear. You're correct. When I'm done, that hole is still there, but now it's cleaned and it's ready to start sealing. Whereas before, the tear would not seal because all the herniation was stuck in it, clogging it up, keeping it from closing. Now that I've debrided it, it will seal. But until it seals, the patient is at risk for reherniating again through that area we just fixed. So you are correct. So how do we prevent that? Number one, restrictions. We make sure the patient understands no lifting over 25 pounds for 6 weeks after their surgery. That will keep them from reherniating. The jelly in the center of the disc is not water. It's not liquid. It's solid. It stays where it was put. But, pressure and trauma on that will fragment it into pieces and break off more pieces and push them out. So we want to avoid trauma. We want to avoid contact sports. We want to give the disc adequate or ample time to heal, and that's going to take a year to fully heal. So I tell everybody it's going to take a year for your disc to fully heal. You have a 25-pound lifting restriction the first 6 weeks. It goes to 40 pounds afterwards for the first year. Wear your collar, the plastic collar, wear that for the first 6 weeks. So those are our restrictions, and they work. If you do those things, you will not reherniate.
That is it.
All right, hope you enjoyed our broadcast. We'll be back on Thursday.
Yeah.
We do have another surgery today. It's Deuk plasma rhizotomy. We're not broadcasting those yet. They're top secret. The reason why we don't broadcast them yet is we're not ready to. It's a newer surgery, a new technology. It's working great, but we're not ready to broadcast it yet, okay? And that's to treat facet joint pain. Facet joint pain, so for those of you who don't know, there's two types of joints in the spine. One is the disc, the second is the facets. And 80% of people's back pain comes from the disc. 20% of those people, the pain comes from the facet joints. And so in the case of the next surgery, I'm going in to do a rhizotomy where I deaden the pain nerves. They're called the medial branch of the dorsal ramus, and I'm going to use a special type of energy to do that we developed